Here we will view the actions performed in rock climbing. First, we see flexion at the knee and coxal joint, as well as rotation of the coxal joint. We see extension of the left leg here, as well as dorsiflexion of the left tarsal joint and adduction of the right leg. Finally, we see a slight rotation of the left knee joint. So here we have a model representing the muscle functioning with the hypodermis, bone, which is represented by the wooden dowel, tendon represented by the ponytail holder, some yarn representing the muscle, and some bubble wrap representing the hypodermis. The hypodermis functions mainly for protection and temperature regulation, but as far as the muscle goes, it allows for the muscle to slide and stretch. When we pull on the muscle, it's able to stretch and flex, lengthening the tendon by utilizing the hypodermis here.
This is excitation-contraction coupling. As you see here, an action potential travels down the axon terminal and releases acetylcholine, which goes across the synaptic cleft to the sarcolemma and down the transverse tubule. Calcium is released from the terminal cisternae and then binds to troponin, removing the blocking action by tropomyosin. This allows myosin cross-bridges to form, which allows muscles to contract.
Here we will view a proprioceptor of a skeletal muscle. The blue straw will represent an extrafusal muscle fiber, and the orange straw will represent an intrafusal muscle fiber. The purple pipe cleaner will represent an alpha motor neuron, and the yellow pipe cleaner will represent a sensory nerve, which communicates to the CNS. When a skeletal muscle is stretched, the intrafusal muscle fiber will send a communication through the sensory nerve, the yellow pipe cleaner here, to the CNS, which then sends a signal back through the purple pipe cleaner, which is the alpha motor neuron, causing the muscle to contract. Here, the muscle is stretched. At this point, the communication would go from the yellow pipe cleaner, which is the sensory nerve, to the CNS. Here we see the signal being sent back down through the alpha motor neuron, causing the muscle to contract.
The membrane potential is maintained at negative 70 millivolts. Graded potentials vary in size depending on the intensity of the underlying stimulus. EPSPs are increases to membrane potential. IPSPs are decreases to membrane potentials. If summation leads to threshold at negative 55 millivolts, an action potential fires. Action potentials do not vary in size, however. If summation leads to a low frequency, the stimulus is viewed as less intense. Then a higher frequency, causing more action potentials to fire, is viewed as more intense stimulus. Inputs are received from axons directed to the dendrite. Temporal summation is adding repeated inputs. Spatial summation is adding simultaneous inputs. If threshold is met due to the summation of the inputs, an action potential fires. During an action potential, ions flow across the membrane, creating rapid changes in the membrane potential. Initial stimulus causes sodium to leak in. When enough sodium changes the membrane potential enough, voltage-gated sodium channels open, causing more sodium to come into the cell, known as depolarization. When the membrane potential reaches positive 30 millivolts, sodium channels close and potassium-gated channels open. Potassium exits the cell during repolarization. The membrane potential then goes below resting membrane potential, gated channels close, and resting membrane potential is restored by the sodium-potassium pump. Unlike with graded potentials, action potentials propagate down the axon. Action potentials are all or nothing, and they travel quickly due to saltatory conduction. Sensory pathways travel through the spinal cord using the dorsal root. First-order neurons travel through the dorsal root to the gray matter. They synapse with secondary-order neurons that travel through the gray matter and up the spinal cord. Secondary order neurons travel up until they synapse in the brainstem or the thalamus. Third order neurons conduct the signal the rest of the way to the sensory cortex. Motor pathways involve upper motor neurons and lower motor neurons. The upper motor neuron either starts in the motor cortex or the brainstem and travels down the spinal cord. Lower motor neurons exit the spinal cord via the ventral root, where they go to effector organs. The dorsal columnar mediated lamiso pathway transmits fine touch, peripheral receptors, and proprioception. The signal enters the spinal cord, travels up the spinal cord, crosses over in the medulla, travels up to the thalamus, where it is then relayed to the somatosensory cortex. The anterolateral pathway relays pain, temperature, and crude touch. The signal enters the spinal cord, crosses over at point of entry, then heads up the spinal cord to the thalamus, where it is then sent to the cortex. Both corticospinal tracts receive input from the motor cortex. That signal travels down to the medulla, crosses over, and out to the effector tissues.
Here we have our ox coxae and femur. So the ligaments that are joining that together is the pubofemoral, ischiofemoral, and iliofemoral ligaments, as well as that synovial membrane in there. So here is the knee. We have the suprapatellar bursa. The patella sits on top of it, so we've removed that so that we can see the anterior cruciate and posterior cruciate ligaments, and also both menisci. The fibular collateral and tibial collateral ligaments are right there, keeping the knee stable. Here is the ankle bones, the anterior tibiotalar and anterior talofibular. And it is important to note that the articular cartilage would also be in here, minimizing friction and absorbing shock for all movements. So the joint capsule was the plastic wrap, and the synovial membrane is that dark blue right there, with the articular cartilage being the light blue underneath. Next up, we have the knee. So as you can see, that joint capsule represented by the plastic wrap, and the articular cartilage underneath. And lastly, we have the ankle. You can see that joint capsule there, and also the articular cartilage.
Bone renews its strength and structure by remodeling. Osteoblasts release a cytokine that causes immature osteocytes to mature. In bone reabsorption, mature osteoclasts use enzymes to dissolve bone. Then mature osteoclasts release enzymes to make immature osteoblasts mature. Mature osteoblasts released osteoprogenerin, which is a protein that deactivates osteoclasts, preventing more bone reabsorption. Mature osteoblasts begin depositing osteoid, which is a matrix that contains minerals including calcium and phosphorus, and a strong, flexible protein called collagen. compact bone makes an organized outer shell and a spongy cancellous structure of thin interlocking plates called tuberculae. Osteogenesis imperfecta is a genetic disease in which bones fracture easily, also known as brittle bone disease. Type 1 collagen is a material that helps make bones strong. The genetic defect causes the body to make collagen incorrectly or not make enough, leading to the weak bones that break easily. It may also affect osteoblast production, causing bone breakdown. Some other symptoms include bone deformation such as bowing of the legs, discoloration of the eyes, a barrel-shaped chest, a curved spine, a triangular-shaped face, loose joints, soft discolored teeth, skin that bruises easily, and hearing loss in the early adulthood. Rock climbing would be incredibly dangerous for those with this disease, as even a small fall can cause breakage and fracture.
A person born with osteogenesis imperfecta will have excessive osteoclast activity with limited osteoblast activity. This creates a problem with bone formation. Thus, somebody with osteogenesis imperfecta will likely have osteoporosis with very brittle bones. In this video, you see the rock climber bouncing off the wall and eventually landing on their feet. This is something that would not be able to be performed by somebody with osteogenesis imperfecta. It would likely lead to a broken bone in the lower extremity.